like more than half of the cases in foreign-born, in some places along the border, even higher numbers. And why is Latin America is not a priority, and also why some funding has been cut in Latin America. So I'm concerned because I deal every day with patients. I receive stories from patients every day, and I know that the things that we hear from other countries that's happening there. But if there is no political will in our countries, if there is no studies, there is no the resources to show that this is a high burden priority for some communities, so pretty soon we're going to have another higher burden countries in Latin America. So I'm concerned about that communities, and I have there are voices that is behind me. So I would like to know that. And for the clinical trials, I would love to know if there is a children inside of the clinical trials, because I know that there's a lack of intervention in children. So I would like to know that. And for the global initiative, I would like to know why it's not looking into the psychological effects of tuberculosis and moving beyond the cure. That means the sequence of tuberculosis is very hard. I've been receiving also stories from communities who already, according to the norms, have been cured, but they are suffering a lot of the sequence of tuberculosis. So there's a lot of rooms that we need to look into that. I know priorities, but I think if we go and see the human suffering, there is no limit to for our ideas. Thank you.
Harold, you may want to take a question on regional.
Thank you. Thank you very much. Yes, I mean, as you saw from the burden of disease, the largest number of patients dying today are in Asia. The largest number of people with TB HIV are in Africa. The largest number of MDR TB cases are in Central Europe, Eastern Europe. So we put the money where the biggest problems are because the donors have limitations. I come from Mexico, and I know the problem. I also know how things are improving in Mexico. And I want to link, just if I can make this additional point, is so much has been happening in the last 20 years. So much success in development in the last 20 years. As part of this community, we can feel proud of that progress. We can see the challenges and we cannot let go. But at the same time, we need to celebrate success and show all of the results, as we have just seen today, of what we have accomplished. Latin America has accomplished a lot. Latin America is a region that has moved, and we have seen people who have worked in Latin America here, but also economically. The engines of growth in Latin America took off in the last 20 years. Yes, and we have seen them in the last 10 years in Asia, and we hope to see in Africa in the next 20 years. That growth, or what I call an economic transition of health, means, as I pointed out in my presentation, that there will be increasingly local resources. We have been working with Mexico, of course. As you know, we still work in Mexico. CDC works a lot more in that regard. USAID, we're talking about the amounts of resources that the US government invests. CDC has a big domestic part of tuberculosis, as you know, work, and that part works with Mexico very closely. USAID put most of the money in Africa and Asia, as we just said before. And at the same time, NIH adds to the totals by supporting the R&D enterprise. But of course, we haven't left Latin America. It is a fact that for USAID, for example, in the last 40 years, we have closed 40 missions. Not out of budgets, out of success. Many countries now are doing things on their own, whether it's on family planning or whether it's on tuberculosis control. That's as it should be. At the same time, we cannot let go, of course, the problems. And we open back for those missions because it's not a simple equation, of course, and we are aware of that. I also would like to invite, I think the point on child survival and the fact tuberculosis also kills children. For us, this year, ending preventable child deaths is going to become the paramount importance for the work of the USG. It's been central to development all along. It's key for the work that we do in PMTCT, in HIV control, and it's also key in the work we do in tuberculosis. So to invite you to join us in that fight to end preventable child deaths this generation.
Thanks. Jennifer, do you want to take a question about children in clinical trials? It seems we're vaccines as well as other tools?
Sure, I can address that for vaccines, but I'd ask Luchika can address the diagnostics, and perhaps my friends from TB Alliance can talk about the new drugs. For new TB vaccines, we are doing clinical trials in children and infant populations. In fact, earlier this year, we finished enrolling with partners in South Africa a phase 2B clinical trial of a vaccine candidate in almost 3,000 infants. That vaccine candidate is now being tested in HIV-positive adults. And we have a second vaccine candidate that has just started phase 2B trials in infants. So that is a target population as well as adolescent and adult populations.
We have our, oh yeah, go ahead.
Yeah, I can say very shortly about diagnosis. And the problem that the answer is so far no. We don't have a diagnosis properly for children, and you know, or those of us being clinicians here, it's very difficult, or doctor, having to do with that, it's very difficult to diagnose TB in children. It's one of the biggest problems, together with the fact that we don't have a child formulation there. So we hope that some people will look into developing a special diagnosis for kids, and we are working with Unitaid, who are promoting development of new tools and as well new formulations for pediatric TB, ARVs, or malaria, in trying to see how we can address that.
And Heather, do you mind saying a word about
And
TB
then just
drugs?
on drugs, I'm not able to speak on behalf of the entire global pipeline that you saw. But the TB Alliance is not currently testing in children, but we do plan to move forward with those studies once we have the safety data to allow us to study the experimental drugs in this population.
Any time frames?
I can get that to you.
And there was a final question sort of about the, I think, psychological and emotional impact of this disease on communities. And Carol, I don't know if you just want to take a moment about, just from System Plus and other organizations you're involved with, what kind of support is available, what kind of support works in terms of supporting patients, not only through the process of undergoing treatment, but then after that as well.
I think, like I mentioned, former patients have now sort of come up and formed groups. Like, for example, the Wisitam is. So now, right now, we have support groups of people living with HIV and AIDS, and then we've integrated TB into that, because it's been very difficult to sort of hold down support groups of just people who have had TB, because usually after they have the TB, they're cured, most of them go off. But in most cases, there's some groups where we have people who just had TB, and they sit together and they support each other. Like, for example, whatever experiences that one went through, and then you support whoever is on treatment. So that's the kind of psychological support that we do at that level. But in my country, I'm sure, I don't know whether you're talking about MDR TB, we don't really have MDR TB cases yet, because I'm sure that's where you have really problems, psychological problems from the treatment. We don't really have MDR TB cases yet, really, in Zambia.
And so part of what Carol was referring to is that the drugs that are available currently to treat multi-drug resistant TB, one of the really bad side effects is actually psychosis, sort of tragic. Other questions? Right here.
Hi, I'm a former patient, TB survivor since 2007, and I had run-of-the-mill drug-sensitive TB, but I went through a lot of psychological anguish, depression, feeling ashamed of having infected my family, and I would have loved having some support. The clinic in El Paso, Texas, where I'm from, had no social worker, had no time or resources to take care of that aspect of the disease. However, I ran into a nurse that was very compassionate and actually held my hand and kind of walked me through a lot of what I was going through. Later on, I participated in TB Photo Boys project and got to know other patients, other people that were going through the same thing. And for me, mentorship, I think, between people that have gone through it before and pointers on what to expect, how to handle things is crucial. And none of that is being addressed in any of the budgets or any of the presentations. However, being patient advocates and I think recruiting support from within our own ranks is the best thing. And being partners, being considered partners in the fight against TB strengthens our role in it as well. Thank you very much for speaking.
Thank you. Thanks for sharing that. Sorry, way in the back.
Yes, I'm from Texas, and I'm with my daughter, and I found out that she had TB when she was 5 years old in the Philippines, and it's a regular doctor visit. And what they did back home is when they found out she had TB, he just sent us to the drugstore and get some medicine. And for 6 months, I was just wondering why, if they have a global health, why this doctor just sent us to the drugstore and get this serum to take for the whole 6 months. And I'm just glad we came here in the States in 2005. And that TB did not really, she really did not get cured back in the Philippines, and it came back in 2010. And I was stigma on her side. We kept it secret because of her being young. In school, we keep it secret. In the family, because when they see you having a TB, it's like, because in the hospital when she got surgery, in the record they see she had TB, they don't even want to come in our room. They're like, I need a pillow, and they're throwing the pillow. And it's really hard for me as a mom seeing her. But if she got cured in the Philippines, we're not gonna end up feeling this these days. But I'm really thankful that over here in the States, they're really making sure, Dr. Stark making sure that she got that cure on TB. And we made a lot of process over here, but I'm really thankful for that. And my question is, why back in the Philippines have not the same process of, if this is like global, if the politics back home, the doctors will work, they have to send us,
I think, yeah, I welcome anyone to sort of take on that question. I think, so thank you, first of all, very much for sharing that, for sharing your experience. I think a couple of layers in there, including the role of sort of private providers and practitioners and sensitizing them to tuberculosis, not only the treatment, but of course the stigma as well. Ariel.
Thanks for sharing that, and it is indeed painful, but I'm happy that she is now being taken care of. And it also illustrates how if you don't do it right when it's simple, then you get all sort of clinical, psychological, and also economical complications, of course. And there are two things I would like to point out. One is, it happens to be the case that the Philippines is the country where you have the most prevalent use of tuberculosis drugs in the pharmacies around. And sometimes you sell it as part of the syrup for cough, and it's really unusual, the Philippines, in this regard. And I'm sure that Michelle has been discussing with the government of the Philippines how we can do this better. Clearly, in many other countries, not only do you have to have a prescription, or do you have to have actually refers to a proper program of tuberculosis control, but all of the tablets are in fixed dose combination. And those countries that have fixed dose combination treatments do much better in terms of the complications of drug-resistant tuberculosis. And then the last point is the private sector. In Africa, 50-60% of the health sector is private. In Asia, 60-80% of the health sector is private. We used to think it was the government, it's actually private, also from providers. And so clearly developing systems, and I think tuberculosis has been, community has been in the lead in engaging, recognizing and engaging the private sector, so that there's a proper collaboration, training and referral into proper programs. But obviously, the job is not yet done. And nonetheless, I would say fix those combination therapies, referral to appropriate dose programs, and the proper framework for working with the private sector in every country is important.
Other questions? Sir?
Thank you very much. I'm from where Carol is. We are visiting. I'm from Swaziland. My name is Muyabaramuna. I have had the share of being a doctor as well. But I think in 2004 I asked myself a question. Is the medical approach of waiting for the patients to be sick and helping them at that point the best approach? And I think the answer to that was no. I'm very, very thankful really for having this opportunity to share my experience these 2 last weeks that we have been here. I think we have had an approach in medicine of actually what I would call sit and wait, and then help, or what one would say a reactive approach. And we haven't had really much to do, and TB has demonstrated that, because we have really confined TB to a medical approach or a clinical approach. And as we have also heard from all the data here, I think that clinical approach is almost failing us. And there are many ways we need to look at and ask ourselves questions, what is the best way to wake up? World Health Organization has been supporting what they call health system strengthening. That's another approach. They thought maybe the clinical is failing, let us support the systems. That still is within the clinical area, and I think it might still fail, because you are strengthening the same system that waits for patients to be sick, and then they help them after that. We have come to Washington to train for ACSM. For me, that is another approach, really, because it's an approach now.
Do you want to say what ACSM is?
Okay, sorry. Yes. Advocacy, communication, and social mobilization. And to me, that is another approach that I think we need to support strongly, because it's an approach now that creates advocates who don't wait, but who go to the communities, mobilize people, tell them what they need to do and how they need to do it. Because really one of the problems within clinical medicine is that most people don't reach the clinical area, and even if they reach, they don't get diagnosed. And maybe they even are not sure of how the process would be for them to be diagnosed. So, but this approach, which to me is very important and needs support and funding, will be helpful in a way. For example, I think Dr. Mendez has been talking about using local community resources as an approach that will be more helpful in terms of carrying out the TB activities. And I think one way of doing that is really raising community advocates, people who understand the situation and who can use that data they understand to rally the communities so that they can also really activate their own countries and their own leaders to act. So for me, I think I would like to appreciate that, and I would like really to pray again and thank the government of the US, but to look at this other approach now. The medical approach has failed us, the health system strengthening approach has also partly not helped much. What about this new approach? And I know there have been a lot of questions within the international community. ACSM is very difficult to measure. How do you know that your activities is the one which has caused this? But I tell you, because the ACSM is really solving some of the problems which the clinical medicine cannot solve. If a patient is failing to come to the clinic, the drugs, even if I increase them, won't make him come. But social mobilization, communication, advocacy might make him come. Thank you very much.
Thank you. And sorry, before any of you reply to that, I just want to squeeze in one last question of the gentleman who has his hand up over here, and then we'll just about wrap up. Please go ahead.
Thank you very much. I'm Francis Apina from Kenya, TB HIV advocate, and I just wanted to highlight a few things. First, I would really appreciate the presentations. They were very enlightening and very edifying. My concern is one, and I feel that this is something that we need to address, especially on MDR and XDR-TB. The national treatment guidelines, for example, need to be expanded. I don't know whether to use the word enrichment or maybe enlargement for that matter, because most of the programs actually deals with the patients when they're on treatment. But how about the exit strategy? How about post-treatment? Because you know, the drugs that are actually used for MDR and XDR-TB have the adverse effects. After treatment for those 2 years, then what happens? I want to give you an example of 2 cases in Kenya right now, where a patient has actually gone through the treatment of MDR under the national TB program at Kenyatta National Hospital. And this patient, because of the drugs that he's taking, is actually has eaten all the lungs. He has only 75% of the functionality of the lung to live on as a result of the drugs that has been taken. Actually, to maintain that functionality, he is spending like almost 10,000 Kenyan shillings every month to be able to live. And this is a result of the effect of the drugs that he's been taking. He goes back to the program and he's told, no, we have already discharged you. I mean, you're no longer our patient, for example. Now, what happens? So I would really urge this forum, for example, of experts to really take this into consideration. The other thing is actually, the other one is actually an XDR case, where the patient is, actually we used to have 3 XDR. We've gotten 3 XDR cases in Kenya, but unfortunately 2 of them died, and 1 is still hanging on. And she's on her own. I'm very disturbed when I talk about she's on her own because no program is taking care of her. Okay, the national program cannot provide the medication. We don't have the medication for XDR in Kenya, and she has to get the medicine from South Africa. The last time we had a meeting of advocates in Kenya, spearheading the same case. I'm happy that the USAID Kenya office pledged to give some drugs for this particular patient. And what the family is spending on this patient is around 16,000 Kenya shillings a week. You know, the family, which is already overburdened. She's a mother, she has kids, she has some other responsibility to take over. But when we're actually now looking at the national guidelines on XDR TB in Kenya, I mean, I'm happy that the WHO has come up with a very good treatment guidelines, but hardly are they being followed, you know, at the national level. I think we need now as advocates, for example, who are here. I'm happy that you're joined by the researchers, the medics, and everyone else, to be able to see that actually what you do brings a change in the lives of patients. I think it would be unpractical to come up with a document, post to the national programs, and then it is never followed. We need some mechanism that can be able to take care of, you know, treatment right from, you know, the 2 months, and also be able to look at, for 6 months, for example, after treatment, any side effect that might come out of the treatment can be taken care of by the treatment.
Thank you. We're just about out of time. I want to give our panelists a chance to react to any of the 2, I think, insightful comments that we've just heard, or any other final thoughts.
I just want to thank you all. I think these comments have been very useful, and it is the granularity of the challenge on the ground. I appreciate that very much to our teams. I just also want to share, our teams have put together the annual report to the Congress on tuberculosis work of the interagency of the U.S. government, so it's available if you're interested. Thank you very much.
Thanks, and whether you're on the Hill or off the Hill or very far away from the Hill, I hope there's something from this afternoon that you can take away and use in our advocacy to try to stop this disease. So please join me in thanking all of our panelists today.